In the UK, most operations are planned weeks in advance.
Right, everyone happy?
Starting.
But each year, around 9,000 patients are so seriously injured.
He's got significant head injury. We've got our code red.
That they need an urgent operation.
Slow slide.
To save their life.
Bleeding quite a lot though, isn't it?
It really makes you value life and how quickly things can change.
Right neck injury, right chest injury.
At University Hospital Southampton's major trauma centre.
Hello, Southampton. What's your UTA?
100 trauma specialists and expert surgeons must bring their skills together at a moment's notice. Under the most intense pressure imaginable.
Things can change rapidly. It's thinking on your feet and thinking fast.
There's no margin for error.
The angle is completely wrong. It's a bit of a fiddle, this.
You can never have an off day when you're operating. You have to concentrate all the time. There is no let up.
From resus
We've dropped his pressures. We pull him out. Pull him out.
to theatre.
It's never as easy as they look.
20 specialisms combine to save one life.
Hello.
Can I give you a level 1 trauma pre-alert, please?
Yeah, go for it.
He's approximately 55 years old, and about 5 p.m. he was involved in a motorcycle versus car where he was a motorcyclist.
A critically ill patient is being airlifted to Southampton Major Trauma Centre.
There was 3 low blood pressures with systolics of 60, so code red, major trauma.
Okay, so code red.
With a code red, the patient has lost so much blood. He's in danger of cardiac arrest.
Is Ursula around as well?
Trauma team leader Ursula Hartley leads the response.
The motorcyclist has gone through the windscreen.
Okay, fine.
It's an immense responsibility. I think it's probably the highest responsibility you can have. Their care is ultimately in my hands.
Adult, level 1 trauma call, ETA 10 minutes.
Ursula assembles a team of experts from across the hospital.
My name's Ursula, your team leader. What we've got coming in is a level 1 trauma of a 55-year-old male. He was GCS 15 with a right radius and ulnar fracture, and he's had an open right ankle which has been reduced under ketamine. He's now a code red. He dropped his pressure to 60 systolic.
60 systolic means that his blood pressure is dropping and therefore his body is starting to fail. If we don't give him blood, he may potentially die in our resus department.
The medics prepare blood products and a machine to infuse the patient at speed.
They've just landed on the helipad, so they should be coming down now. Ready? Quiet!
Good evening, everyone. This is Christopher. He's not currently hugely stable. Following us loading him onto the aircraft, he had a drop in his blood pressure. We didn't find an obvious source for his bleeding, but have commenced a code red blood transfusion for him. This is his second unit that Tom has in his hands.
We don't know where the bleeding is coming from. There's no signs of bleeding externally. The fact that he's continuing to be so unstable despite treatment means that it must be something quite severe that's bleeding internally.
I'm going to look after you. Ready, set, lift. Thank you.
Shaking and in a state of shock, the trauma team need to stabilise Chris as quickly as possible. Nurses deliver transfusions to replace lost blood. An anaesthetist gives medication to help his blood clot. And an advanced clinical practitioner examines Chris for signs of the bleed.
Like, will you a CT scanner, please?
Chris has now been given 5 units of blood. That's half the body's entire volume of around 10 pints. His injuries are so severe, they decide he needs to be fully sedated before having a scan.
Airway secure.
He's patent.
IV cannula secure.
Yes.
Go to CT.
That's fine.
The CT scan will take a series of X-rays to create a detailed image of inside Chris's body.
Jimmy's dropped his pressures.
But before the scan is complete, Chris's blood pressure drops again.
We pull him out. Pull him out. Yeah. Call Joe, get some blood.
Call the red nurse. Tell her to bring 2 units to the scanner.
Give him a unit of blood. It's not very often we'd stop their scan and take patients out of the scanner. That's really, really unusual. We have a dilemma. Chris is really unstable, but we need to find out where the bleeding is coming from.
Genuine question now.
Should we do Joe? As a trauma team leader, I still have to remain as calm as I can because at the end of the day, I'm leading the team. In my head, I just need him to have the scan done as quickly as we can. Let's just give this. If his systolic is over 80, we need to preload him with some blood to bring his blood pressure up, pick our moment, and then literally get him into the scanner as quickly and as safely as possible.
Blood pressure over there.
Yeah, run him through. Just do the scan. We'll do it really quickly.
I think he's actively bleeding.
So they get that. He's actively bleeding from his pelvis.
The scan reveals that when Chris slammed into the car windscreen, he fractured 2 bones in his right arm, crushed his right ankle, and broke his pelvis in 2. And it's there where a pelvic artery is bleeding, with blood collecting at the bottom of his abdomen.
All of Chris's fractures need surgery, but before we think about that, we need to manage Chris's internal bleeding as soon as possible.
Should we give IR a call?
Yeah, can you do that?
Chris urgently requires a procedure known as IR, or interventional radiology, where X-rays are used to guide tools inside the body to identify and stop internal bleeding.
So we're going from here to resus while IR get ready, and then from resus to IR.
With Chris close to death, consultant radiologist Sachin Modi is called in to perform the procedure.
You get one of these phone calls about a patient that's seriously unwell, it focuses your mind and suddenly your adrenaline kicks in and you're in the zone. Okay, on the screen there. The patient in front of me is relying on me to save their life. I need to find the bleeding point, otherwise he could bleed to death. Okay, so tube going in.
Sachin must use the X-rays to guide a wire and catheter inside Chris's body through a network of hundreds of blood vessels to find the bleed. Then he'll insert a tiny metal coil in the leaking artery to block the vessel and stop the bleed.
That's my wire going up and catheter's following.
He navigates the wire by twisting it delicately with his fingers.
You need to be dexterous. Very fine movements outside the body cause movements inside the body. Now we're on the right side of the pelvis.
Sachin injects a dye, colouring the blood, which should highlight where the vessels are damaged and leaking.
So this vessel doesn't look completely normal. I think that might be bleeding.
We can have a little fun there, please.
With the bleed located, Sachin pushes 2 tiny platinum coils up the catheter, all the way to the injured vessel.
Once inside the blood vessel, they release like a coiled spring. No bleeding there. Okay, not bleeding from there. Okay, there's no active bleeding at the moment.
They're done.
Done.
Perfect.
Sachin has plugged the bleed and saved Chris's life.
It's a big relief to find stop the bleeding. to save lives. It's the best feeling in the world.
After 4 hours of emergency treatment, Chris is taken to intensive care, where he will be monitored overnight.
Although I have stopped the bleeding for Chris, he's not out of the woods yet. He still has a lot of other serious injuries which will need to be operated on.
Tomorrow, Chris's body will face another assault. Several hours of complex surgery, where surgeons will attempt to repair his shattered body. With almost 2,000 major trauma cases a year, University Hospital Southampton treats the most severely injured patients in the region. But even the smallest accident can be the most life-changing.
Southampton General A&E, Nathan speaking.
We come in with a 72-year-old. Tesco had a fall this morning.
A man has broken his leg at home by falling down the stairs. Emergency doctor Samir Abdul Karim takes charge of the trauma response.
Trauma work has shown me that seemingly small, innocuous injuries can lead to big trauma, particularly in the elderly.
Good morning.
So this is Frank. As he was coming down the stairs, his knee's gone. He refused the pain relief. Eventually took some of his paracetamol.
Elderly patients in general are a lot more stoic. They don't really kick up a fuss when it comes to pain. And that can cause issues. That might make you become falsely reassured.
When we got him into the stretches, when we noticed that his leg instantly went purple.
The colour of Frank's foot indicates it's not getting enough blood.
Hi Frank, my name is Sam, one of the doctors over here. Let's have a look at this.
It's virtually at 90 degrees.
The issue with fractures is if it's in a position that's compromising the blood supply, if you don't set it back in time. That can have massive ramifications. The end stage would be potentially losing a leg.
Right, guys, X-ray.
It's incredibly easily done. Whilst going down, I thought, oh no, what a stupid thing to do. You always think it's not going to happen to you, but yeah, it's happened.
Yeah, it's a spiral.
The X-ray reveals a long twisting fracture down the tibia, known as a spiral fracture.
Probably when you planted your foot down, your knee gave way.
Yeah, my whole body twisted round, but the foot stayed
planted, yeah.
The broken bones can crush or twist blood vessels in the leg, reducing the blood supply and causing tissue to die. So orthopaedic registrar Tom Moore is called to resus.
It's something which ultimately is likely to need an operation.
Really?
The priority is to get it into a good position.
Frank's fracture is so complex, it will need surgery to repair it. But first, the bones must be realigned to restore the blood supply and save Frank's foot.
So with regards to sedation, we're probably going to go for ketamine, midazolam as well.
Do you want some Penthrox as well?
Morphine. As in pre-induction, yeah.
It's not a very nice fracture, and I'm just thinking more is better.
Yeah. Trying to fix the leg and resetting it. It's painful. It's really painful. The medication we'll give you is pain relief and also kind of dissociative, so it'll make you feel like you're not part of the whole hustle and bustle here, okay?
First, Frank is given Penthrox for pain relief.
Breathe on it like an inhaler.
So,
Midazolam to induce a relaxed and sleep-like state. And ketamine, so he disassociates from the experience.
you're very safe. It's important to me that patients are calm and they're reassured and they feel safe. Good. Traction here. Sort of a nice crunch.
No, we haven't really improved it. It's still displaced. I've made it no better at all.
Muscles in Frank's leg are holding the bones in the wrong position, so the surgeons must try again.
The peak concentration of the drug is around 2 to 3 minutes, and it starts to wear off after 10. And that's the window of opportunity we have. there. How are you doing, Frank?
Yeah, in your world, almost.
You're almost in our world.
Magic, thank you.
The surgeons have repositioned the bones enough to allow blood to flow to Frank's foot, but they're not perfectly aligned.
We're looking a bit better. Still needs an operation.
This is a temporary hold. The only definitive step is surgery.
He still needs a complex operation if he's ever to walk normally again.
You're not going to 100% fix every single person's problem, but what you can do is start the path of getting them to where they need to be.
Less than 24 hours after his motorcycle accident and life-threatening internal bleed, Chris is stable enough to face major surgery on his pelvis, leg and arm.
The blood has been done and oxygen tank is done.
Without it, he won't have proper use of his right arm and may never walk again.
Working in trauma makes you consider just how quickly life can change for you. None of our patients expect to sustain the injuries that they present with. A split-second circumstance can change their life immeasurably.
To repair the fractures to his pelvis, leg and arm, 3 specialist surgeons will operate. Pelvic surgeon Chris Mitchell, lower limb expert Joe Round, and arm specialist Sharif Fatoa.
To have multiple surgeons operating simultaneously on the same patient is reasonably uncommon.
By having multiple teams operating together, we can reduce that amount of time the patient's on the table, and it means we can stabilise the patient from their injuries at an earlier stage.
Chris has already sustained a huge injury to his body. The faster we can complete the surgery, the better for him.
Chris will be placed in a cruciform position to allow at least 2 of the surgeons to work on the fractures at the same time. On the left of Chris's pelvis, he has an open buck fracture where the bones have sprung apart from the impact of the accident. At the front, Surgeon Chris will use a clamp to pull the bones into their normal position. And at the back, he must precisely place guide wires, avoiding vital bundles of nerves which control movement and sensation in the legs, before fixing it in place with screws to pull the fracture together. And finally, stabilizing the front of the pelvis with a metal plate.
With an injury of this magnitude, it's very unlikely he'd be able to walk again if this fracture were not managed surgically.
To repair Chris's shattered ankle and tibia, Joe must first wash out the open fracture to remove dirt and fragments of bones which, if left in place, could cause infection, before constructing an external metal frame around the fracture to hold the bones in place.
Frames are really useful in orthopaedic surgery as they allow us to hold complex injuries and give them stability.
Finally, as Sharif works towards the fractures in Chris's arm, he must avoid damaging important nerves before aligning the breaks in the radius and ulna and fixing them with titanium plates.
Even though one is very careful, one can injure the nerves or the arteries. It can be really life-changing if we get that wrong.
For the 6-hour operation, the 3 surgeons will be supported by a team of 13 trauma specialists.
Okay, so I won't get
including an anaesthetist, 2 registrar surgeons, 3 scrub nurses, and 2 radiographers.
Fixing trauma patients is definitely a team event.
1, 2, 3, lift.
Okay, down you come. Every member of that team needs to play their part. To a certain extent, you're having to tune out background noise in the room and focus very carefully.
First, Chris and Joe will start on the most urgent fractures.
Good, X-ray there, please. Lovely. Starting.
Surgeon Chris starts by making a 10-centimetre incision in the lower abdomen to access the pelvis.
So we'll do put that in there and lift it up. So this is all altered blood.
Immediately his progress is blocked by the now clotted blood from the internal bleed that almost cost Chris his life.
All this stuff in here might be in our way. One half of his pelvis has become separated from the remainder of his pelvis. We may need to apply a lot of force to bring this pelvic fracture back together. So that's caught. Yep.
He uses a clamp to force the bones to meet.
And then we slowly bring it in. You can see it coming to bear now. Coming together there nicely.
Meanwhile, Jo begins her procedure on Chris's shattered ankle.
Let's have some
wash on that. That is reduced. Yeah.
Reduce it. The biggest risk with an open fracture is infection. It's the one we worry about. If you can't treat it, it can lead to loss of that limb.
Any bone or tissue without a blood supply could cause a dangerous infection.
Bony fragments on it. The patient's ankle joint is badly smashed up and is in multiple pieces. We try to maintain as much of the joint surface as we can, but we have to remove small fragments.
Okay, I'll have a knife when you're ready, please.
As Jo cuts away dead tissue, further up, Chris has come to the most challenging part of his procedure.
So if you get yourself squared up to the patient now.
Repairing the break at the back of the pelvis.
Guide wire ready, thanks.
To create a pathway for the screws, Chris first drills in guide wires.
You're going to aim in that direction, so push it through the skin. X-ray there, please.
But he must avoid vital nerves which control movement and sensation in the leg.
X-ray, please. This is a very high-pressured part of this operation. If you drill that hole in slightly the wrong position, the screw will not follow the correct trajectory and will carry risk of damage to the adjacent nerves. X-ray, please.
Surgeon Chris uses X-ray for guidance, but it doesn't show nerves. So he uses his knowledge of anatomy to identify safe corridors of bone for the wires.
So you're changing in so many dimensions, there's so many variables. We're working on a 3D problem, but only using 2D imaging, so it's entirely possible for it to be perfectly safe in one view, but dangerous on another view. Every time you change the angle in one view, you are changing it in the other. Full speed. That's annoying, isn't it? X-ray there, please. Inserting these wires can be quite a frustrating process. The angle is completely wrong. It's a bit of a fiddle, this.
Chris's work is so delicate, any movement of the patient's body is affecting the angle of the wire.
I might get you to pause.
Yeah.
We're fighting each other.
Is it the moving the leg that is getting in your way?
A little bit.
The other surgeons have to stop, so Chris can get the right angle for the wire.
At that point, it's all about taking a deep breath, going back to the first principles of positioning the wire safely and start the process again to ensure it ends up in the right place. We'll pull back, we'll bend this wire and then re-advance it. X-ray there, please. Oh, look at that, much clearer. Let's see how that's going to go, shall we?
The guide wires are in position.
X-ray, please.
Now Chris can drill in permanent screws which follow the wires into place.
So, yeah, start advancing it there, that's fine, yeah. X-ray, please. Lovely, keep going.
Chris, you happy for us to drill a couple of holes in the leg?
Yeah, please do, yeah.
Yeah. Operating in multiple teams can be like surgical ballet. Knowing your part and how you play that part can be like dancing around each other.
Jo can now continue by drilling in screws and metalwork to create a frame that will hold Chris's shattered ankle together.
Yeah, X-ray there, please. Yeah, that's fine. X-ray there, please.
To finish his work on the pelvis, Chris fixes a metal plate that will hold the bones in the correct position.
We're doing all this
Right,
again.
that's going down there. So if you just hold that there like that, got it? Oh, hello. Can x-ray that in a minute, make sure we're happy with it. But... Lovely, look at that, one pelvis.
After 2.5 hours in theatre, the pelvic surgery is complete. Joe must now finish the frame on the ankle.
X-ray there, please. Save that, please.
Yeah. As the third surgeon, Sharif, starts his operation on Chris's broken arm.
This hand is going to serve him for the remaining years of his life. It's really important to get every detail right.
It's delicate work. Unless it's done perfectly, Chris could struggle to use his right arm and hand.
Is the superficial branch of the radial nerve. The radial artery.
Yeah.
Just there. There are vital structures that go through the forearm. At least 2 important nerves and 2 important arteries that I have to navigate and protect throughout the operation. This is the nerve supply to the flexor cardialis muscle. You can see the damage to the muscle because of the break. The most difficult part of the operation is try to reduce the bone back where it should be.
As he manipulates the bones back into place, Sharif must work gently around the nerves. Even slightly stretching them could cause permanent numbness or weakness in Chris's right hand.
Now it's looking good. Hopefully we'll be all right. Can we have the plate now, please?
With the fracture reunited, Sharif uses a 10-centimetre titanium plate to hold the bones together.
That's good.
Now he must fix the second bone, the ulna.
If I don't get the right alignment of either one of the 2 bones, that can really affect the way he uses his forearm. Every time he tries to open a door or tie his shoelaces or pick something from the floor, he might find that difficult, or he might find that he has to do it in a different way to compensate for the lack of movement. Can you relax there? Take this one out. Yes, very good. 7-hole plate, please. We'll go with the 1 hole at the fracture site and 3 hole proximally, 3 hole distally. Start closing up.
At the ankle, Jo finishes her procedure by tightening the frame to secure it in place.
Okay, we'll give it a little finger tight.
Yeah, I got it.
Bend the knee up. X-ray there, please. Save that, please.
With the bones returned to a normal position, the shattered ankle can begin to heal.
I am amazed at what frames can do. With this type of fracture, previously people would be looking at amputations.
Finished. Yes.
Okay, flash there, please. It's looking very good, so you can see both fragments are solid.
After 6 hours in theatre, the 3 surgeons have finished their operations.
As a surgeon, we witness lots of life-changing events. We can only be there to try and help pick up the pieces.
Chris will now go to intensive care and begin his long road to recovery.
Most motorbike injuries are unfortunately life-changing injuries. Very few would go back to absolutely normal life.
Across the country, over 15,000 people are injured in motorcycle accidents every year. They're often the most critically injured patients treated at Southampton's major trauma centre.
Southampton Emergency Department. I have a trauma patient for you, please. Okay, go ahead. He has crashed his motorcycle into a tractor.
The patient is coming from 40 miles away.
He has a significant left-sided chest injury.
Charged with leading the response is consultant Alistair Moffat.
The motorbike went inside of a tractor.
Alistair must manage the 15 specialists assembling to save the patient's life.
I've asked cardiothoracic to come down because he's got an open chest wound as well. Hi. Ortho, fabulous. Okay, welcome everybody. My name's Alistair. I'll be your trauma team leader today. Gentleman was on his motorbike and went into a tractor at 11:45 this morning. When a young person comes in having suffered a major trauma, it does generate a different environment amongst the whole of the team. The emotion that's at play can be quite significant. We know that he's got neck and chest injuries. He's been intubated and ventilated at scene. If you do notice anything as you go along that you think is important, please feel free to raise it immediately. I'd much prefer we know about it sooner rather than later.
Emergency medics sedated the patient at the scene as he was distressed and couldn't be properly treated.
Good afternoon. Table for a hands-off handover.
This is Hayden. He's a 19-year-old lad. Right neck injury, right chest injury.
Great, thank you. Let's get some across, please. From the moment the patient arrives in the department, the clock is ticking. We need to identify their injuries as rapidly as possible and intervene as quickly as we can.
The trauma team must identify Hayden's most life-threatening injury. An emergency doctor examines him for visible signs of trauma, and an intensive care doctor and anaesthetist assess his breathing and heart rate to understand how his body is reacting to his injuries.
Alistair, I'm happy with the airway. The pupils are size 3, equal and reactive.
He's got radial pulses. He's warm peripherally.
Can we let CT know? And we'll want to get CT as soon as possible.
As they transfer Hayden into the scanner, he must be kept completely immobile.
Trauma patients can have dangerous injuries that are hidden. The CT scanner can yield surprises. It can find injuries that you weren't anticipating.
Radiologist Matthew Morgan makes an urgent assessment of the scan.
So this is the area that's concerning me the most. You can see there's a fracture through all 3 columns, anterior column, middle column, and also the posterior column is involved as well. Seems to be stable.
That's unstable fracture.
Our concern is for injury to the spinal cord if this isn't fixed.
If that bone slips, then the risk is that his spinal cord will be damaged, and that can lead to paralysis, essentially from the waist down.
Hayden will need surgery to stabilise his spine to prevent paralysis. But there's a more urgent issue with his chest.
This region here on the top of the lung image is concerning me. I can see there's a pneumothorax, several locules of gas which are outside of the lung.
Hayden's lung is punctured, and so air is able to collect between his lung and his chest wall. That can push the heart sideways and mean that blood isn't able to get into the heart and out of the heart. And that obviously is a life-threatening situation.
The trauma team insert a drain to release the air.
Oh, there we go.
But there is a risk that it may have already caused some damage.
The biggest issue is infection. If any bugs have come with that air, that can be very serious indeed.
Hayden's mum, Vicky, has arrived at the hospital.
So he's still asleep at the moment, and we need to keep him asleep whilst we keep an eye on his lungs. He'll be pain-free because he's got lots of drugs on board, and it always looks more dramatic when they've got tubes down, when they're tied to the bed. They never quite look like the person that they're but he's doing fine. He's lovely and safe around.
As a parent, you can imagine yourself in that situation. You can imagine your own child having been involved in that accident. You have to hold that emotion in check, even if you are internally, emotionally feeling that this could have been your child.
Not good. No, he's going up to intensive care soon. Can't speak to him, he's on a ventilator.
Hayden is transferred to intensive care to await an operation to secure his broken spine. Until it's fixed, any small movement could damage his spinal cord and leave him paralysed. After 3 operations on his pelvis, leg and arm, motorcyclist Chris is recovering in hospital.
Memory's a bit vague at the moment about everything, even up to this point. When I actually did come out of the coma, I'd had all this done to me, which I didn't even realise had happened in the first place. Most surreal situation. I know I had a hell of a lot done.
Chris still needs months of rehab. If it goes to plan, he should be able to walk normally and use his right hand again.
The hospital's been fantastic, I'm going to be honest, you know, the people. Yeah, I couldn't praise them enough. If it wasn't for these guys, I wouldn't be sat here now, would I? I think sometimes you've got to sit back and take a look at your life. And, yeah, this has done that. I look forward to getting home, be able to enjoy some of the things that you spend all that time out there trying to earn money for, you never actually enjoy.
How is your pain?
It's fine, yeah.
On the trauma ward, 72-year-old Frank is facing an operation to fix his badly fractured tibia.
I'm usually a pretty positive person. I didn't sleep at all well last night, thinking about it.
His surgeon is orthopaedic consultant Simon Tilley, an expert in lower limb trauma.
Morning.
How you doing? Simon Tilley.
Hello.
Nice to meet you.
Hello, Mr. Tilley.
Is it okay if I just have a quick look at the leg and the skin in particular?
Yeah, sure.
Yeah.
To fix the spiral fracture, Simon plans to put a metal nail down Frank's tibia. But under the bandages, there's an unexpected surprise.
Right. So this presumably wasn't there when you did the injury?
No, it wasn't.
Okay.
That's not nice, is it?
No. You've got a big blister here around the back, and the skin has come off here, and you've got another blister here. You can feel the bones trying to poke through the front of the skin.
Fracture blisters can occur as part of the body's response to significant trauma.
If we start violating this with holes in there on top of the trauma here, there's a not insignificant chance that the skin can die, and then we're in real trouble.
It certainly seems more serious than I imagined.
Because this is potentially a limb-threatening injury, unfortunately.
If you've got an area of dead tissue over the bone, the risk of infection's high. If the skin does die, there is an increased risk of subsequent amputation. We do everything we can to avoid that.
Simon can no longer perform the planned procedure, as it involves putting screws directly through Frank's damaged skin, which could cause a limb-threatening infection.
Especially with trauma, we do see very rapid onset blisters. It changes plans hugely.
Instead, an external frame will be attached to hold the broken bones together without disturbing the blistered skin. Once again, the surgery requires frame specialist consultant Joe Round.
I think we can probably avoid the main blister.
It's always a bit daunting being called into surgery at the last minute. My colleagues are all very experienced, and it's usually a problem that you're called in for.
To create the frame, first Simon and Joe must make tiny incisions avoiding the blistered skin and drill 2 pins into the bone above the fracture. Then a long pin will be inserted through the heel. These will be connected with bars and bolts to form a triangular frame. Joe and Simon must then realign or reduce the bones into position before tightening the frame to secure the bones in place.
Clearly a bit of a challenge. I hope that it'll go according to the plan that's been set out. It's the unknown, isn't it, that is the worrying bit.
Hi again, Frank. How are you doing? Brilliant.
Joe and Simon are supported by a team of 9 trauma specialists, including radiographers, scrub nurses, anaesthetic nurses, and anaesthetist Rachel Broadley.
Has that made you feel a bit floaty yet?
I'll rate it in gin and tonic.
I will make sure you get your money's worth. Pleasant dreams. We will take really good care of you, and the next thing you know, you'll be in the recovery room.
The bone is trying desperately hard to come through.
Okay to start. Thank you.
First, Joe drills 2 15cm stainless steel pins into the leg, avoiding the damaged skin at the ankle. Then connects the pins with a carbon fibre rod.
Are you ready with a knife, Joe?
And creates a base for the frame with a 4mm wide pin through the heel.
No, you've got to keep going. Stop. Thanks. There we go. Don't go down that way.
Now they can attempt to align the fracture.
Okay.
When it comes to the manipulation, you can look at the limb, you can sometimes feel the bone, but you are slightly blind as to what's going on until you get that x-ray.
Let's just have a quick look at the reduction.
X-ray, please.
Just there, please. Thanks. There's a load of stuff in between, isn't there?
The X-ray shows the 2 halves of bone haven't come together. And although they can't see it, the surgeons can feel soft tissue caught between the bones.
These are never as easy as they look.
Can we loosen that as well?
Can I? Yeah, well done, thank you.
The surgeons try to move the soft tissue again, so they can bring the fracture together.
Still way too tight there. I'll keep my finger on it.
Okay. So.
Yeah, and give it a twist.
We're trying extremely hard to get the fracture fragments back into alignment, which is really very difficult to manipulate the soft tissue out of the way.
Okay, and just relax. That's feeling good.
Finally, Joe and Simon think they've aligned the bone correctly.
Happy for me to let go?
Yep. No, it's gone.
Sometimes it just doesn't go the way you want it to go.
I think everybody has moments of self-doubt. Am I going to get this reduced? Is this patient going to be okay at the end of it?
My worry is if it's close to the artery as well.
If we're not progressing in a reasonable amount of time, there is ongoing trauma to the soft tissues. The only other option is to make a small incision to sweep the tissues out of the way safely.
We're just not winning. Just wondering if we do a little nick.
Where were you planning on putting the...
Right there.
Right, through that threat in the skin.
It's almost a no-win situation. If we have to go through damaged skin, we could get infection in the bone. The most devastating effect of that could be a loss of limb if we're unable to treat it.
We should give plastics a call then and just say, look, we're going to make a little anterior neck.
Yeah.
Simon and Joe decide they have to do what they wanted to avoid. Cut into Frank's damaged skin and risk a significant infection.
Do you want to give him a call?
So Simon calls a plastic surgeon as they specialise in repairing damaged skin.
Hi, Simon. Listen, we're doing the X-fix. There's a lot of soft tissue in there.
It does feel a little bit of a failure to have to open up, and I think it's always worth trying right up until that moment you make that incision.
Just keep hold of that so I'm not rotating the top. That's it.
And again, please.
Are you happy for us to do just a mini incision anteriorly?
There is a part that doesn't want to admit defeat.
That feels better. Some play in the skin. X-ray, please.
Oh yeah, I'll do it as far. Oh, hang on. Oh, she's nearly done it. She's nearly done it. Yeah. No. I think we'll get it. I think we just need to do a bit of tweaking now.
It is even more satisfying when you can reduce that fracture without having to open it up, especially when you've been struggling.
All right. Thanks a lot. Thank you. Cheers. I think we're going. That's feeling good. So we've got continuity. That feels like a tibia now. Right, let's have a look. That's fine. Good. And again there. That's fine. Yeah, we'll accept that. Fine. Brilliant. Well done.
Now with the tibia aligned and the fracture brought together, they can secure the frame in place.
Just tighten these last two up. Then we're done. Happy?
Yeah. Trauma is completely reliant on teamwork, and that's particularly true when things get tense, when things don't go quite as well. It's absolutely essential that you've got a team that picks up on that and they help you through it.
Well, that was hard.
But it came together really nicely, actually.
Yeah.
The main thing is the skin's safe.
We support each other. We are there to help when there's a problem. And there's always someone you can call to help out.
Well done, thanks for that.
That's all right.
Please, ready, steady, slide. Hi. You're just waking up. Open your eyes for me.
Frank has a long road ahead of him and may need many months of treatment to get him back onto his feet again.
After a second operation to fix a fine wire frame around his tibia, Frank's now recovering at home.
This is where the accident happened. My knee gave way on this step here. My leg was twisted, made a very nice job of breaking it.
With the new frame, Frank can finally bear weight and walk.
Walking with a frame is not too bad. Some days there's more pain than others. To be back home is fantastic. The freedom to be able to decide what to do and when to do it. I will remain a positive person even after this experience. I've every confidence I'll be back to where I was. I'm very grateful to the surgeons. They've been more like friends, I think, which surprised me. They're very, very friendly people.
I imagine every patient on the table as being a first-degree relative, and I've always subscribed to that. It's part of the incentive to do the best job that you can to get them back on their feet.
It's 2 weeks since 19-year-old Hayden was seriously injured in a motorcycle accident. But because of a life-threatening chest infection, he's been too ill to have the operation to fix his badly fractured spine.
Oh, you feel nice and warm.
His surgeon is spinal consultant, Michael Quay.
All the time that he is lying in that bed, his spinal cord is effectively at risk because the spine around it is broken. Until his spine is put back together and held together in a secure way, there is a risk he can have a spinal cord injury, which would lead to paralysis.
But today, Hayden's condition has improved enough that Michael decides the surgery can go ahead. To repair Hayden's broken spine, Michael will carefully navigate down to the broken vertebra. Then he will drill 8 titanium screws above and below the fracture, carefully avoiding the spinal cord just millimeters away. Any damage could paralyze Hayden for life. Finally, to stabilize the spine, 2 titanium rods and a cross-connector bracket will secure everything in place.
Hayden's heart and lungs are still not in a great shape. It's a big operation, it's risky. The reality is this could end up being a very difficult procedure and very quickly.
It's my baby lying there, even though he's 19, still my baby lying there.
Operating on young people like Hayden, you have a very strong sense of responsibility. You are trying your best to get him back on his feet.
In Theatre H, a team of 13 are preparing for Hayden's operation.
Hayden's been in with us now for a few weeks. He's had a really ropey chest. He's had pretty marked chest sepsis actually since he's come in, so he's a bit delicate.
For the surgery, Hayden must be placed face down on the table.
Mike, do you want to supervise the roll? Controlled as we can, okay? Nice and gently, please.
But this will put pressure on his damaged chest.
Come on. The major risk really is that by lying him on his front, either his heart or his lungs don't take it very well.
Okay, SATS probe back on, all the monitoring.
The sooner we get him off the table, the better. Right, Tom, making a hole.
To access Hayden's spine, Michael makes a 30-centimetre long incision.
Bit easy.
As a healing mechanism, the body sends blood to the site of an injury.
Getting quite a lot there, isn't it? Yeah. Let's try and find this bleeder.
No, another one's on this side now.
Right now, Hayden's bleeding a little bit more than we would expect. The bleeding definitely does slow you down a little bit. We want to try and get on top of it as soon as we can.
Michael must find and cauterize every bleeding vessel before he can start.
Give that a little buzz in there, something lurking under there. Nice, good man.
The bleeding has settled down quite a bit.
It has, yeah.
Finally, the bleeding vessels have been burned and sealed.
See what we need to see there.
But it's taken 30 minutes, more time that Hayden has spent on his weak and damaged chest.
You all right? You're in, Tom?
Yeah.
Now Michael must work quickly and with great precision.
Right, let's have the starter finder feeler.
He uses a starter tool to create a tiny channel for the first screw.
The hole that we're drilling to put the screw in is literally millimetres from the spinal cord. If you drilled into the spinal cord, we would almost certainly paralyse Hayden. That is a real risk. Okay, flash that, please.
He checks the position is safe on X-ray.
Okay, yep, that's too below the broken one, isn't it?
Yep.
The screws will go into a tiny sliver of bone, called the pedicle, just 1 millimetre thicker than the screw itself. As Michael gradually increases the size of the hole, he must avoid breaking through the bone.
Having direct feedback from hand tools is very important because you know that you're in the right place, and given the margin of error that's involved, you can't be in the wrong place.
Just widen it up a bit so it takes it slightly bigger.
If you go too long, you're looking at the blood vessels. If you go out to the side, there's a risk of damage to the lungs.
And press again. Nice, good. Okay, burned all the way around. That's good.
Only when he's happy with the hole can he safely insert the screw.
Yep, and again. That is. That's a good hold.
Now, he must screw in 7 more.
Yep. For every screw that you put into the spine, there's a risk of damaging structures around it. You have to concentrate all the time. There is no let up.
Bottom screws are in, the top screws are going in now.
Hayden has spent over an hour on his chest, but there are still 4 more screws to go.
Little bits on the top. Okay, give that a flash, please. Okay, that look very nice.
The final screw is in place, so Michael can insert the titanium rods, joining the screws together.
These are the tulips, these are the things that hold the rod. So there we are. We're just going to put a cross connector over the top. That's it. Rock solid.
Hayden's spine is now secure.
Let's have final x-rays, please. Good stuff. Lovely.
He will now recover in intensive care.
My hopes for Hayden is that Hayden leads a pretty normal life after this. But the reality is I don't really know how he's going to be when he wakes up.
While the operation's been a success, they won't know if Hayden's spinal cord sustained any undetected damage in the accident until he wakes up. It's been 2 months since surgeons operated on Hayden's broken spine.
When he was in intensive care, I just struggled to comprehend that it's my son lying there with all these tubes going into him. It was frightening. Just didn't know how he was going to recover and if I was going to get that little boy back.
I remember waking up in hospital and walking out the ward and all the nurses running after me and all of them saying, like, one of them even said, "You can actually walk." I was like, yeah, of course I can, because I didn't know really what happened at that point. And then obviously they filled me in on what happened and all of that sort of stuff, and that's where I realised, man, I was in a serious accident.
2 months ago, I wouldn't have even thought he would be up and running like he is now. The injuries that he had.
You all right? Yeah. I think the thing that I'll take away the most with myself is just be grateful for what I've got in life. Just be grateful for the friends I've got and family. Oh, I am extremely thankful to the surgeons.
The thing about trauma cases is you have often the ability to take someone from a very bad situation and turn them around. When you get someone who you think, well, they've come in and they are so vulnerable, and you can sort them out and get them back on their feet. That's a good feeling.